medications have, in the case of vials, a sealing technique that helps prevent their integrity. For example, here you see drugs like midazolam, fentanyl, and ketamine. And it's really important if you use a medicine like this that is subject to, what do they call it, redirection or misdirection, or we'll just call it what it is, stealing. Before you administer it, you make sure the cap is actually working. What do I mean by that? We'll take magnesium for an example. These caps are pretty ingenious. They cover the port that you access. The cap should not come off, and it should be able to freely spin. This is the case with any of these here. We have some Benadryl. Same thing. It doesn't come off. Some adenosine. Same thing. And so on. Let's take some Zofran or ondansetron. So we have the same thing. Let's pretend this was, I'm going to give this. I want to make sure that the cap spins. If for some reason someone had stolen this, say we're talking a narcotic, they might have popped the cap, leaving the little injection thingy here, drawn out the medication, and then refilled it with something else. Typically just normal saline or whatever. You wouldn't know. You can't really tell. Most of them look the same. And then taking this cap, and with a little spot of crazy glue, you can kind of see the inside of the cap. It's got like this little wheel, I guess. Take a drop of crazy glue, and I can do this. No, I can't. And glue it back on. The cap's going to look perfectly normal, but now it won't spin. So now if you are giving a medicine and the cap doesn't spin freely but is stuck on, it's a very high likelihood it's been tampered with. You wouldn't want to use it. So how is this important? I never knew this, but we actually had an engineer who came from Ventura County Fire. They had one of their fire guys, I believe it was Ventura County, I could be wrong, this was a while ago. One of their guys had busted his leg on an incident. So they went ahead and gave him, at the time, morphine for the pain. And when they gave the morphine, the engineer didn't respond. So they gave him some more from the same vial, and there was no response, and so people started to think he was maybe faking it or whatever. Well, as it turns out, there was just saline inside that vial. When they had popped the cap off it, they hadn't noticed that it didn't spin, and someone had tampered with the vial, taken out the morphine for him or herself, and whatever, and that screwed that engineer over. So in the case of narcotics, which are obviously much more susceptible to being stolen, that would be a big problem. And in my own experience, my own preceptor from way back when, who was an awesome guy in every other respect, apparently developed some sort of condition in his abdomen and started taking medicines from the narcotics stash by doing the same thing. And I wasn't caught for some time, and he was using the pain medicines for himself. And what made this particularly egregious was that people who got narcotics, opiates, whatever they were using for their pain were getting just water or normal saline. And this is a real problem. I can't imagine this happening with other medications, because other medications are not really controlled. But it's still a good idea to understand that if that cap doesn't spin, in the sense of the rights and dice acronyms that are used for integrity, this is a major factor in the integrity of a medication. Is that cap spinning and attached before you use the medication? So hopefully this was helpful. And thanks for watching.
Hi there. The previous video was meant to cover the security or integrity of vials, in particular vials that hold medications that are more likely to be pilfered. For example, benzodiazepines, which is stuff like Ativan, Versed, Valium, ketamine, and then of course any opiate type drugs, for example morphine, fentanyl, Dilaudid, and the like. As I was going through the video though, I was reminded of a really important thing, and that was that one guy from Ventura, he was on a mission, because when he had seen how badly this engineer with the broken leg suffered, it really bothered him. And I applaud the guy for having enough motivation and feeling this enough to take this upon himself. Why? Well, you recall from the video that his own peers started to get suspicious when he didn't respond to the pain medication they thought they were giving him. And it's kind of this ugly truth in EMS and allied health in general, allied health by which I mean anyone under a physician, to think the worst of people pretty easily. We tend to, sometimes get jaded by, druggies and substance abusers. And I also kind of went through this phase where you use this little moralizing, like, oh, you don't need that, or suck it up, or if it was my ankle, I wouldn't be crying so much. And I grew out of that, thankfully, after a few years, realizing that it's not my job to moralize medicine. And so what if they're being a drama queen? I don't care. The medications don't cost me a dime. We don't carry enough to kill anyone. And if it gives a person some peace, whether it's in their mind or not, who cares? They're at peace. It doesn't have to be a fight or a competition, my standards versus theirs. But that brought to mind a separate issue, which I learned only recently, and that was the genetic variability in people and their response to medications. The field studying this is called pharmacogenetics or pharmacogenomics. And what they're doing is basically realizing that those genetic differences apply to how people respond to medicines as well. So, for example, one person may respond to morphine super well, and another person, it doesn't touch them. One person may respond to Dilaudid, and the other person is unresponsive to it. And by what I mean by responsive is in several areas. The studies show things like how well it relieves their pain, how much it is likely to cause respiratory depression or nausea, and even like does it cause their pupils to respond like you would expect with opiates. Typically opiates cause pupillary narrowing or constriction, pinpoint eyes. So why is this important? There's two stories I can relate to you. One was while I was reading a book about some special forces operators, and one of the guys wrote in his biography how he had his lower leg shot in his tibia, his shin bone. And it was pretty much destroyed from what he said. He was actually had to be medically discharged afterwards. And while he was being medevaced by a military transport aircraft, he was asking for pain medication. And at the time, the primary pain medication was morphine. Well, the nurse started to get suspicious because he wasn't responding as most people would respond. So she started giving him a hard time, got suspicious, and he was now like kind of desperate and at the same time mightily offended at this, this, what do you want to call it, attitude. And more, it's like the attitude that people who think they know it all but don't have in greater quantities than the people who actually know a whole lot and are very modest and humble about the limits of their knowledge. Fortunately, a physician overheard this. So the physician basically told her to shut up and give him a different pain medication, as this guy was apparently genetically unresponsive to the normal pain med, which in the day was morphine. Fast forward to my one personal experience with this, and that was I was transporting a guy with severe back pain, and I had given him fentanyl, which is what we carry, and it didn't seem to really affect him at all. And I was kind of frustrated, like, this sucks. I've had back problems myself. I don't ever underestimate just how agonizing that can be. Brought him to the hospital, and in the emergency department, they gave him Dilaudid, another type of opiate. This worked like magic. Fixed the guy right up, at least got rid of his pain, and that was that. And I'm thinking, okay, well, go figure. I have a patient that I'm assigned to transport out of that hospital to another hospital, what we call interfacility transports. And he also had serious back pain. I think he was a veteran also. And he was just ridiculous amounts of pain, and they'd given him Dilaudid after Dilaudid and basically called it quits. They're not going to give him anything more. Maybe they thought he was acting. I don't know. I didn't care. So I gave him my own fentanyl. And wouldn't you know it, that worked fantastic. Knocked down his pain. We could move him without causing him to scream. Drive him over to the other hospital without every bump causing him a lot of pain. And I was super happy. He was super happy. We were super happy. In fact, I'll say it, at this stage of my career as a paramedic, I am very, very gratified and just happy when I can take away someone's pain. So a lesson to EMS people out there, nurses, whoever the hell else is given pain meds, don't assume when it comes to response to pain medications that there isn't a genetic variability to it. And it's probably not going to happen in my lifetime, but I foresee a day when people will be genetically typed for their response to all sorts of medications, including blood pressure control medications, pain control medications, etc., etc. So that way things get more efficient and appropriate for the individual. All right, thanks again.